Good morning, everyone. My topic is a rare presentation of multiple cranial nerve palsy in a case of multiple myeloma. A 47-year-old male patient came to hospital with history of left eye defective vision for past 1 month, which was gradual in onset, progressive and painless. History of binocular diplopia for past 1 month with horizontal separation of images more on left gaze. History of left eye deviation noted by the family members 1 month back. Past history, he is not a known case of any systemic conditions and he was not on any regular medications. Family history was not significant, and general physical examination showed a moderately built, well-nourished person, and he was anemic. No cyanosis, icterus, and lymphadenopathy was noted. On ocular examination, he showed a left face turn of 15 degree and right eye findings were within normal limits. In left eye, the visual acuity was 6/36 improving to 6/18, and on Hitchcock corneal reflex test, left eye showed 15 degree esotropia. Anterior segment findings of left eye showed clear cornea, reduced sensation, and pupil was dilated and fixed. Other findings were within normal limits. Ocular movements in right eye was normal, and left eye showed limited abduction on levoversion and minimal limitation of elevation and depression and limited depression on adduction. IOP was normal in both eyes, and clinically second, third, fourth, fifth and sixth cranial nerves were found to be involved. We refer the patient for neuroimaging. MRI brain and orbit showed a large hyperintense mass in sphenoid sinus extending superiorly to compress the optic nerve and posteriorly compressing the brainstem with extension into the left cavernous sinus with involvement of left, third, fourth, fifth and sixth cranial nerves. This other image showing sphenoidal lesion, and that is CT MRI showing multiple destructive punched out lesions replacing most part of the vertebral column, skull vault, right side of the ramus of mandible, zygoma and sphenoid body. And further blood investigation showed hypochromic microcytic anemia, and on electrophoresis there was increase in lambda light chain with normal kappa lambda ratio, and a diagnosis of lambda light chain multiple myeloma with intracranial plasmacytoma was made. Discussion. In India, the median onset of median age of onset of multiple myeloma is 55 years. Multiple myeloma presenting with neurological symptom is very rare. It is almost around less than 1%. Intracranial plasmacytomas has been classified by Clark into 3 groups. Group 1 is plasmacytoma arising from skull base with multiple cranial nerve palsies, and Group 2 is intracranial tumor syndrome, and Group 3 is intraorbital tumor syndrome. Neuropathy, it can be peripheral neuropathy or compressive neuropathy. Peripheral neuropathy is usually due to the deposition of antibodies against and myelin deposits, or it can be due to drug-related myelopathy. Cranial nerves, among cranial nerves, 6 nerves is most commonly involved. They are highly chemosensitive and radiosensitive tumors, and plasmacytoma with underlying multiple myeloma has poor prognosis. Multiple myeloma may be included in differential diagnosis of multiple cranial nerve palsy, although ophthalmic signs are rare and generally occur late in the course of disease or as a complication of treatment. Early diagnosis and institution of chemotherapy helps increase the survival rate in such patients. Thank you, and these are my references.